Hi, good afternoon, everyone. Thank you so much for joining Jeff Foundation's virtual workshop series. My name is Danielle Edwards. I am Jeff Foundation's Community Engagement Manager, for those of you who do not know. We are super excited to be hosting this neurobehavioral and psychological care in Duchenne muscular dystrophy with Seth Sorensen from Arkansas Children's Hospital, who will be kicking it off for us in just a moment. So I'm going to pass it over to you, Seth, and we'll be taking questions at the end. Just please feel free to drop them off in the chat. Thanks so much for joining.
Great. Thank you very much, Danielle. As I mentioned, or as you mentioned, I'm going to be talking about neurobehavioral and psychosocial care in Duchenne. Let's open my slides. Come on here. And so I am I'm a clinical neuropsychologist at the University of Arkansas for Medical Sciences and Arkansas Children's Hospital here in Little Rock, Arkansas. A little bit of a delay. So first, I just want to speak briefly about the rationale for establishing and maintaining neuropsychological care with our boys with Duchenne. So first and foremost, it's really important to recognize the fact that Duchenne's is not purely an orthopedic type condition, but it does have direct brain involvement, the same thing that is responsible for muscular weakness. The dystrophin is also expressed in the brain, and we know that these boys with Duchenne's have variable expression of that, and we are, under the assumption and belief that those differences in brain dystrophin underlie a lot of different, a lot of these different presentations, all these different behavioral, emotional, cognitive learning type issues that we see manifest in these boys. Developmental delays are common in these boys, so it's really important to establish neuropsychological care early. These cognitive and learning issues, they generally persist without additional evaluation and appropriate treatment. So it's really important to identify these things and establish, again, that neuropsychological care. But at the end of the day, in everything that we're doing from a neuropsychosocial approach is to enhance the quality of life of these boys, as well as the quality of life for you guys as a family. So just briefly, I think there's a lot of differences in understanding knowledge about neuropsychological evaluation. Some of your boys have probably received neuropsychological evaluation. Some of your boys alternatively might have received some school-based evaluation, or maybe had an evaluation done, maybe not by a neuropsychologist, but just a general psychological evaluation. But just want to talk briefly about what what the evaluation entails. So neuropsychological evaluation is a comprehensive, thorough evaluation conducted by a neuropsychologist. So a neuropsychologist has a clinical psychology background, but with advanced training in brain behavior relationships, which makes it neuropsychology. We'll do additional testing, evaluation procedures that a school will do, but with a more sophisticated lens from a neurobiological perspective, if you will, understanding not just what it looks like, but where it's coming from inside the brain. But in order to gather all of our information, in order to put this all together in a meaningful way to translate over into providing education to you guys as parents and the teachers and school, making the appropriate recommendations, involves data collection, which is a review of our overall history, education, medical, behavioral background. We do conduct an interview. We usually interview you guys as parents, interview the child, see what's going on as far as emotions, behaviors, stressors, how we're coping. And then we do neuropsychological evaluation, direct testing. So that is to determine brain-based processing, strengths and weaknesses. Every single person, every human, whether it's you or whether it's your boys, we all have different strengths and weaknesses. And it's really helpful to identify those. What are our strengths? We can use our strengths to manage more of our weaknesses. And we aim to kind of adapt educational processes and interventions in order to target our weaknesses. and it's really important, again, to harness those strengths. We also use the data. We look at it within ourselves, see what our own strengths and weaknesses are, but it's also important to see, okay, where do we fall? Where are our skills relative to other kids, our boys' age? And at the end of the day, when we put all that data together, we can come up with an appropriate diagnosis. That diagnosis subsequently opens up different avenues for treatments, different interventions, different, whether it's psychotherapies or medications. But we really view it as a roadmap for education, a roadmap for treatment, and a roadmap for success, and a roadmap for enhancing that overall quality of life. Just, these are the functions that generally we would assess. These are either direct one-on-one assessments, again, assessing actually how the brain's functioning using these different tasks, or some of it might be questionnaire-based type things that you or the teachers might be asked to complete, like speech, visual, nonverbal skills, learning, memory, attention. That's our ability to sit, focus, do boring things even if we don't want to. Processing speed, just how fast we can process information, efficiency, executive functioning skills. So executive functioning skills, that's like the air traffic controller of the brain, if you will. It has to be able to do a lot of different things. It's the planning, it's the organization, it's the working memory, it's the ability to follow multi-step instructions. It's the child's ability for you to tell them, go upstairs, brush your hair, brush your teeth, put your shoes on, and then we're going to school, right? Looking at fine motor skills, academic skills, reading, writing, math, and then of course those emotions, behaviors, social skills, and adaptive functioning skills. So that might be toileting skills, ability to, do day-to-day activities at home, care for ourselves. Those general activities of daily living are all things that we assess and incorporate into a comprehensive evaluation. So when we're able to put all the information together, we write that report, pass it along. We want it to be reviewed by the parents. We want it to be reviewed by teachers, schools, and any medical providers working with these boys. We want to help the educators understand and work with this child, again, using the strengths, manage the weaknesses, tailoring their information processing, different approaches for optimizing their learning, their ability to pay attention. Some of these kids, again, you have to break things down into small chunks. Other kids can't process as quickly, so you have to give them extra time, things of that nature. It's really important, again, in these kids with Duchenne's and any kids with these orthopedic conditions where it impairs our ability to walk or ambulate, is that a lot of the times I think it just gets viewed as an orthopedic condition, and then people don't consider all the nuanced, really important things that are going on cognitively and emotionally and behaviorally. And the fact that Duchenne's is, again, there's brain-based differences involved, so it's really important to put all that information together in a meaningful way so that it's digestible, understandable, people can relate, and get the appropriate things put in place and have an appropriate understanding. Having an appropriate understanding, having the appropriate diagnosis can really help foster that compassion and support, because otherwise sometimes we're left to coming up with our own interpretations as to why a child is not following directions or why they're not listening to us. But when there's a brain-based reason and it's understood that, okay, this is something that, he can't help and he's not doing these things intentionally, it's a lot easier to be compassionate, be patient and understanding, and taking those appropriate steps to help the child. It's really important, again, to have the accurate diagnosis so that we can come up with an individualized intervention. So just because we're having trouble with one thing, the same thing as another child, doesn't mean the same interventions are going to work. But by doing an evaluation, getting a good understanding into kind of the sophistication of very specific skills, oftentimes we can individually kind of tailor different interventions for these kids. This data is also helpful for guiding transition plans, whether it's transition plans from, middle school to high school, but most importantly, thinking about around the age of 13, 14, trying to get this initial transition plan in place, thinking about long-term adult care. So it's something that we should start early, and something that these evaluations can be helpful with, to see exactly what our functional skills are, what sorts of things should we look for as far as additional services moving forward into adulthood, because really our aim is to help every single individual live as long as possible, as healthy, and as independent as much as possible. And with a good understanding of our strengths and weaknesses, with the appropriate interventions, a lot of people who can really gain a lot of independence in their medical and personal self-care. And that's what those transition plans are for, and that's what our services aim to optimize. Lastly, again, the individualized education program or 504 accommodation plan are different school programs that these boys oftentimes will qualify for. So there is some differences. So an individualized education program, for instance, we would probably recommend that be put in place if he's having specific weaknesses with academic skills. We are underachieving in certain areas, or we do have significant cognitive limitations that are impacting our ability to, complete the same regular education coursework at the same rate as other kids. Versus a 504 accommodation plan, it's more in place to help accommodate any disabilities that prevent the child from being able to fully access their curriculum. So things of that nature could just be, additional time to ambulate between classes, or different mobility supports, or just some basic accommodations, more time, more flexibility, maybe some additional breaks built in, whatever it is. But maybe, the boys that just require a 504 plan don't necessarily have the same kinds of learning or cognitive issues that would impact their ability to succeed more independently in a general education classroom. So developmental delays are really common in these boys. Of course, we know that the motor weaknesses are there. That's the presenting issue that gets people referred, worked up, and evaluated for that initial diagnosis of DMD, right? But it's very common, actually, that verbal delays are present, and oftentimes verbal delays might even be more apparent, if you will, talking about those very early years. It's not unusual for the motor weaknesses to present maybe age 2.5, and you go to your PCP and you get the referral, maybe neurology, and then that diagnosis is made by age 5. But when you look back, there's a lot of those kids that do have verbal delays early on, and it's not unusual for a person to be initially diagnosed with Duchenne's at 5 or 6, only to see that they had already had a previous diagnosis of a language disorder, or possibly even a social communication autism spectrum related disorder, because language delays are common. We also see that social communication delays are common, and those things together do present with some of the very reminiscent of an autism spectrum disorder. There is some characteristic features, though, that separate an autism spectrum disorder versus general developmental delay or language disorder. And the best kind of differentiating features there is the presence of restricted interest and or repetitive behaviors. Those two things in combination does not necessarily mean that the child does have an autism spectrum disorder, but those are at least some core diagnostic features that does help to differentiate those groups. Now, as far as the prevalence of these things, I really don't want to get too bogged down in that. And every child's so different. And, we always say if you've seen one child with an autism spectrum disorder, you've seen one child with an autism spectrum disorder. And the same rules apply to kids with Duchenne's. If you've seen one child with Duchenne's, you've seen one child with Duchenne's. It's just that all these symptoms, all these features present so much differently, and that's why it's really important to have an individualized, approach, diagnostic assessment lens to look through. But I think depending on where you're at and what clinics you're in and what providers you're seeing, again, you just might hear different things as far as whether if we're concerned about autism spectrum disorder, whether or not they meet criteria for it, and why or why not. But there is a lot of differences if you look in the literature of Duchenne's and potentially the prevalence, but also when you're talking about kids without Duchenne's, you're just talking about kids diagnosed with autism in our general population. There's a wide range of what's being diagnosed and different criteria and who's doing the diagnosis that really makes a lot of different numbers and rates out there. But it does vary substantially by state, by region. But in general, the general population is between 1% and 4%. A lot of the research out there says similar rates in Duchenne's, but I think as more studies come in and we start taking a more sophisticated look at it, I think it'll be very clear that rates are higher in Duchenne's, but even without making that diagnosis, there's going to be symptom overlap, which I will discuss here shortly. But other features, other neurobehavioral issues that are common in these boys is that, we're moving through, maybe we have the diagnosis, maybe we don't at the age of 5 or when it comes time to transition to kindergarten or first grade. A lot of these boys just have a lot of challenges transitioning to a more structured environment, new situations, a lot of environmental stimuli, dealing with a ton of other people, structured rules, structured time. That can just be very challenging for these boys initially. We do see that a lot of these boys are diagnosed with ADHD, or if they're not diagnosed with ADHD, they show a range of symptoms, characteristic features of ADHD, such as inattention, concentration difficulties, again, those executive functioning difficulties. Maybe they're impulsive. I think it'd be more argumentative. They have difficulties dealing with transitions, but ADHD rates report anywhere between 10, 12, up to 50%, depending on the samples out there. There's a wide range of emotional behavioral issues. Anxiety, depression, the rates are fairly common, or fairly consistent with a lot of other medical conditions in youth, but with Duchenne's and the progression of the muscle weakness and the implications that has socially and the implications it has, and we were able to do this and now we can't do this. We just see that, with age and disease progression, that risk does increase over time. They're not as able to, do all the same activities as maybe they were before, increased social isolation. All those are stressful on these boys. Obsessive compulsive disorder is also something that's been cited with pretty high rates, and up to 5% maybe have symptoms of obsessive compulsive disorder. Now, whether or not they meet full criteria for that, it is very true that a lot of these boys just show increased behavioral rigidity, which oftentimes can look like OCD, insisting that we have to do things a certain way or being very uncomfortable if things are deviated from our typical routine. That does not necessarily mean it's obsessive compulsive disorder, but it can look like that. But again, regardless of the diagnostic heading used to describe those types of features, we do see that rigidity and some obsessive compulsive symptoms are more common. Now, these things do not commonly occur independently. More often than not, if we have one of these issues going on, more than likely we have multiple going on. So comorbidities are quite common. So this diagram at least speaks a little bit to the complicated features of these boys with Duchenne's. In particular, the overlap of symptoms when we're talking about, whether this boy or that boy meets criteria for an autism spectrum disorder. And each of these bubbles here really show different features, all of which are, common in Duchenne's, and they're all common in kids with autism spectrum disorder, but not all these kids, again, meet criteria for an autism spectrum disorder. Not all these kids have the same cognitive issues. Maybe they have a lot of social issues, but they don't have speech issues, or again, any combination of these things. But it's really important that, again, we're seeing these things, and it can be very confusing as parents as teachers, and we need to figure out what's going on. Again, the best way to get a good understanding is to have an evaluation done. But you know, it's a it's a puzzle, a diagnostic puzzle, and it's something that can evolve over time. But it's really important at least to be aware of the different kinds of symptoms and presentations these boys can show, and really educate yourself in understanding again these different things that can happen, and knowing that again it's not you know, parenting issues or anything like that. Some of these boys can just be challenging, show a lot of different symptoms. So overall, when we're talking about cognitive abilities, when we're talking about, you know, their ability to process information, a lot of these boys might not have any major concerns, but there's a lot of variability across the boys. When we do see that there's cognitive weaknesses, or maybe there's not cognitive weaknesses, that generally persists over time. We don't see that they're really at risk for deterioration, cognitive functions, or anything like that. But without intervention, say we have a speech language delay early on, with appropriate interventions, we can see that those skills can be improved, or that at least we don't see any major weakness or decline in scores across time. However, if we have those weaknesses early on and we go several years without any interventions to address those language delays, then we can see a drop in score. But it's important to note that that it's not a loss of skill, but those scores go down relative to other peers that are making more progress. But it can look like a plateau. So what that just means is that compared to other individuals without those interventions, you know, they're just not making as many gains as maybe other typical peers without those language issues in that example. Overall, as far as overall intelligence goes, you know, these scores are normed on general population. Mean is 100, standard deviation of 15. These boys, for the most part, just on average, we do just see that, you know, there's a lot of variability, but they are about one standard deviation lower, putting them in what we'd consider to be those, you know, maybe the lower end of the average range, or low average range relative to other individuals. Intellectual disabilities are more common than the general population of these boys, anywhere between 20 and 35%, with about 3% having really severe intellectual impairments. And we do see that there are different, you know, expressions and different isoform abnormalities that do seem to affect that, with the DP140, the shorter forms, the DP140 and 71, really being more, having more risk, if you will, cognitively, both for intellectual disabilities and attention-related challenges. So one of the most key findings that we see, and I probably alluded to it before, is that oftentimes we do see that our verbal skills are lower than our visual skills. Basic language is often preserved, basic maybe, you know, uh, academic knowledge or receptive vocabulary, but when we're asked to do more abstract or quickly processed verbal information, we can see that those scores can be a bit lower relative to more nonverbal skills. So these boys, for the most part, are going to benefit, a lot of these boys, from, you know, hands-on visual learning, visual problem solving. So, you know, if that is the case, we definitely want the teachers to be aware of that, so we can adapt their instructional strategies at school. As far as the language weaknesses, it's very common for kids with autism spectrum disorders to have language weaknesses. And again, just having language weaknesses does not mean that you have an autism spectrum disorder. It really comes down to, again, the overall picture and other symptoms that we might see. Just as I mentioned, again, the visual skills are often stronger. All these boys are visual learners. Um, some of these skills are even attenuated in our literature. Their visual skills might be, again, more average, because a lot of the ways that we measure these are, you know, it's really taxing other weaknesses that these boys might have, especially as we get older. Maybe we're not able to, our visual motor skills get slowed down. We're not as coordinated, so that affects their speed, and a lot of visual tasks are really impacted by attention and speed demands. So it is important to note that a lot of the times I think visual skills are underestimated in these boys, so it's important that the person assessing them consider that. First, learning and memory, again, consistent with the verbal skills being lower, one of the most hallmark features or core deficits we see in these boys is that immediate short-term verbal memory, regardless of where their IQ is often, if I were to take a guess at one single weakness, that's what it would be. So if you're maybe asking them to, you read them a story, short story, and you have them repeat it for you verbatim, or you just say, a bunch of different numbers to them, have them repeat back to you, that short-term kind of attention based task is really going to be challenging for them relative to other tasks. Attention can be disturbed in several different ways. Not everyone has attention issues, but it's not uncommon for us to see both simple and sustained attention. So under really boring conditions, is this child going to be able to continue to focus, pay attention when they're not interested in the things? And just relative to other peers, they're going to have more challenges with that, especially if there's speed and additional motor demands. Executive functioning problems, they're not specific, so it's really, as far as when we're assessing them, if we have difficulties with working memory, it's very likely that we're going to have difficulties with planning and or organization, or some combination thereof. In our everyday life, that can present in a lot of different ways, but I think, one of the most frustrating things is executive functioning challenges for parents, because it's not that we don't have a skill. A lot of times it's just that we're inconsistent in our application of those skills, and that's what we see. It's just like they're able to do a certain task today and the next day, and then all of a sudden the third day it's like they're unable to do it, and the person's just left scratching their head. Like, I know you knew how to do that, but really it's really just kind of sometimes some days you got it, some days you don't, and those executive functioning skills can get disrupted quite easily in these boys. Academically consistent, again, with mostly language-based deficits, both in learning and memory and IQ, as I've mentioned. About half of these boys have learning or reading disorders, and a lot of those symptoms really do look like what we consider to be dyslexia. So dyslexia is not just a reading disorder, but it has an additional component to it, and that is really disturbance in phonological awareness, our ability to, decode words, put them together, sound symbol pairings, and if we have difficulties reading and decoding a word, then oftentimes we have those same difficulties when it comes time for spelling. So really the hallmark feature is phonological awareness challenges, difficulties with decoding, and it translates to both reading and spelling related issues. It's quite common. Math and writing, it's less studied. I can say less about it, but qualitatively, we know if we're going to have motor challenges, writing's going to be challenging. If we have reading challenges, writing's going to be challenging. Math is more, again, does have more visual aspects, and I think in more visual mediated math, these boys can probably do a little bit better when it's hands-on and visual. But the fact of the matter is, a lot of math still requires language skills, the same part of the brain that controls those functions, and we do see that weaknesses are going to be more common in those areas. Moreover, a lot of math requires working memory skills and attention to be successful. So if those things are weak, they're going to have more challenges. Just briefly, corticosteroids are really important. It's a key component to management in these boys, and we just cannot stress enough how, again, it's really important to get this in place and use as prescribed by your neuromuscular team. But it was really challenging for a lot of parents to continue to give the medications when it is quite common for these boys to have increased mood or behavioral issues. So it's estimated up to 50% again of patients will experience some kind of mood or behavioral issue. It can result in increased anxiety or depression, increased rigidity or obsessive compulsive related issues, and cause additional sleep issues. And unfortunately, I don't have too much data as far as Duchenne's in particular, but just typical boys or typical patients, if they're taking corticosteroids, we know it does have a way of changing the hippocampus, at least temporarily, while we're taking them, and that can cause some differences as far as verbal memory. And if you recall just a few moments ago, verbal memory is one of the first things, one of the key deficits that we see in boys with Duchenne. So it is possible, again, that corticosteroids can exacerbate those things, but it does not, again, eliminate the importance of taking corticosteroids as prescribed by your neuromuscular team. So in order to deal with these issues and in order to be prepared for these issues, again, an evaluation can certainly be helpful. Working with your psychosocial team, whether it's your psychologist or social worker, to manage these challenges and prepare for them when we're going to be starting corticosteroids or when we're changing dose. A lot of the time, again, those issues manifest mostly during the initial weeks or changes in dose, inconsistent use, etc. But again, it's good to be knowledgeable, aware, and so that we can plan ahead of time. As far as the interventions go, first line treatment is always behavioral psychosocial intervention. So whether it's psychotherapy, combination of psychotherapy with additional supports, accommodations at school, that's what I would consider to be first line treatment, and that's for mild to moderate symptoms. Same as boys, any child without Duchenne's. Same rules apply with medication. Moderate severe symptoms, first line treatment in combination with medication is warranted. So both psychosocial intervention, psychotherapy, as well as medications. Same kinds of rules apply with medications in these boys. I know that there's a lot of anecdotal kind of reports out there. Certain medications may or may not be as effective. These boys are just more complicated and more complex. So first thing we try just is not likely to be as helpful in very kind of pure diagnostic cases of just anxiety or just depression in typical boys. They're more complex, so I think there is a lot more trial and error that we're going to have to work through to figure out what works. As far as briefly specific interventions, anxiety and mood, again, it's not every intervention is to be treated as equal. We look for evidence-based interventions, things that are supported by science. Just going in and talking to someone, playing therapeutic Jenga is not as helpful as having a structured, evidence-based therapeutic session where you're building skills, you're learning coping strategies. They are working with the parents to reinforce those skills, what activities to do at home to learn and acquire these skills to increase our resilience over time. Those are really what we're looking for. There's a couple listed here. Cognitive behavioral therapy is the most probably common, accepted, universal, that works for a lot of these boys. However, in more rigid patients, you might have to switch your strategy a little bit. Acceptance and commitment therapy has gained a lot of traction. If it's more, personal kinds of challenges, role changes, acceptance of kind of our social standing, if that really we think is going to be a key component, interpersonal psychotherapy could be an option. As far as obsessive compulsive disorder, again, cognitive behavioral therapy, but does require a little bit more specific interventions. It's important to have this, what we call exposure and response prevention. Basically, excuse me, different strategies to make sure a person isn't avoiding these anxiety-inducing situations and making sure that we're able to withhold kind of the compulsive behaviors. We do that over and over again. We can resolve those obsessive compulsive symptoms. Now, the general behavioral interventions, ADHD-related interventions. So this is anything that's externalizing, not internalizing anxiety, mood-related issues, but it's more oppositionality, arguing. It's the not following directions. It's the attention or impulsivity issues, doing risky behaviors, things of that nature. Um, Best methods, again, is there's only a few things that are really helpful, and that is one, medication management, and two, what we call behavioral family therapy or parent training. Sometimes I think people get stuck on that label. Parent training, what does that mean? Like, I'm a bad parent? No, it absolutely doesn't. 99.9% of the things you do all day, every day as parents is right. It's spot on. It's accurate. It works, or it should work, right? But my guess is that your child did not come with a user manual, right? So it's really important to work with a therapist, to learn different skills or strategies, to work uniquely with your child, just to tweak things, to troubleshoot things, just to, again, really enhance what we're doing all day, every day. It's really a process of behavioral family therapy or parent training. Parent-child interaction therapy is another treatment, kind of similar principles. Really, it's about establishing increasing connection between child and parent and how they interact. Oftentimes that's for kids under the age of 7. But all of these interventions, again, it's about tweaking things. And you guys as parents, you just have to understand behavior problems are common in all children, but especially these boys, right? Doesn't mean that you're a bad parent. Just these children are complex and the brains are different. And when the brains are different, then they show different emotions and behaviors. And we just have to change things a little bit. It's really important, again, as much as possible, strive to have a normal family life. You have the same expectations as siblings, but do know, again, things do have to be individualized to the child, and we might have to change things a little bit to meet them where they're at cognitively, where they're at emotionally, where they're at in their life. And it's really important that you as caregivers to really aspire to engage in personal self-care. We're no good to our kids if we're not taking care of ourselves. So, go out and, have some social time, get some respite care as needed, network with other parents, support groups, continue to exercise and get out in the sun when it's nice, right? Um, Really, again, it's really important to engage in self-care. Just the last couple of things, other interventions. We know, again, kids who are intellectually impaired or if they have autism spectrum disorders, gold standard treatment there is probably applied behavior analysis. It's pretty intense interventions to really help with self-regulation, whether, if you're doing self-harming behaviors, um, enhancing communication. Oftentimes it requires direct post facilitation anywhere between 20 to 40 hours a week, depending on where you're at and what's available. Those interventions are really helpful. Kids who are, excuse me, kids who are higher functioning and maybe they are cognitively high functioning, but they still have social issues, may or may not have an autism spectrum disorder, but they just have some social challenges. And just social skills training, social pragmatic training can be helpful. One-on-one with a speech therapist or even in a group is really ideal. Sensory processing issues are common in these boys, either, if that's in combination with another diagnosis or just by itself. Oftentimes, an occupational therapist can work to address some sensory issues. Talk a little bit again about the 504 and IEP. It is just so important that we get that school plan put in place as soon as possible. The sooner we put these interventions in place, the better the long-term outcomes are. Less stress, that child has to deal with, less emotional kinds of issues that might manifest secondary to, failure or not feeling supported at school. So again, really important to get that put in place, driven by an evaluation. Now, all academic interventions, again, are treated the same, so it's important for that to be data-driven. What information from the assessment can really, can we use to say what more specific interventions required? And, some interventions are required 4 times a week. So sometimes, dose as well as specific intervention can be helpful. Just making sure they have, again, the most appropriate accommodations. The most common ones you're going to see in pretty much all these boys, whether it's a 504 plan or whether it's a IEP, is using those visual strengths that a lot of these boys have. Emphasis with visual technology, hands-on learning is helpful. attention, executive function, supports, breaking things down, more time, flexibility. It's all really helpful as they get older, helping them with self-management, planners, organizational strategies are all helpful, and then mobility, physical supports are all going to be really required with these boys. Talked a little bit about the transition plans earlier too. It's important to start early. 13, 14 is really where we start to think about it neuropsychologically. These are things that you work with the your teen boy. You work with the school. You work with your medical providers to really get these key things established and put in place, and at least thinking about it. Housing, transportation, that transition to adult medical care. What does this look like after we turn 18? Some of these boys can go on and they can get higher education if they want, with good again management of their disease and good academic attainment, assuming we continue to get all these resources, and thinking about how do we maintain social connections, what types of support do we need, after we turn 18, thinking about guardianship or power of attorney in different aspects, and then of course having advanced care directives put in place, established as well, are all really important considerations. I have a couple additional slides at the end, just with additional resources and things. You can take a look. I know all of these things don't apply to everybody, but I just want to put additional resources in there for anybody who might have some thoughts. But sorry, I clicked all the way through. Don't know if I can get back. Anyway, thank you very much for your time. I really appreciate always being invited by Jet Foundation. Feeling so, again, supported from them. And again, you guys are very lucky to have all these good, great organizations out there, and they're certainly great to have you guys as parents. So thank you very much. I'm happy to field any questions or comments people may have.
Awesome. Seth, thank you so much for that presentation. It was fantastic. Right now, we're just going to be opening up the Q&As. Seth, I do believe there's some questions in there already, if you can see those.
So let me take a look. I see my chat bar. I don't see any questions there. I see the attendee list. Questions. Let's see here. I see a list. Oh, yeah. So I'm happy to read these aloud. Everyone, we think everyone will be comfortable with me reading these aloud?
I would just say the question, if you don't mind.
Mm-hmm.
Perfect. Thanks.
Yeah, I would just leave out the asker and just ask the question. Yeah.
Yep. Let me take a look. I just have to read silently, and I'll read the question. So here's a good question. It's about kind of the transition with COVID. Again, I hope everyone's safe and comfortable. Huge transition for everybody. For most people, that is a huge stressor. But in this situation, this is one where, we transition home, and all of a sudden, the boys having a lot better time getting along, not as stressed, not feeling as overwhelmed. That is an excellent question. So you're seeing that, and you're wondering if homeschooling could be an option next year, or something that would be recommended. That it really comes down to your personal preference. I would just say in general, it is very rare for me to do an evaluation and recommend hard-handedly to move a child to homeschooling. But I know there are a ton of instances where, again, it's night and day, just in the daily stress that they're experiencing, or us, how it plays out, in our everyday life, where it could be beneficial. But it is just really important to consider that, school's not just about the education. It's not just about reading, writing, and math, but it's about all these other things that are important life skills and important for the child to develop anywhere between, again, the social interactions, being able to deal with different people, doing things that we don't necessarily want to do, don't want things that we don't like. But it's not something that I can answer just kind of broadly. I guess it really comes down to individual choice and preference. There are some times where, especially if the school's just not supportive, or say this next fall, if we're going kind of between having in-person class or online classes, things like that, seems like that would be very stressful. So for these boys who oftentimes are rigid, have a hard time dealing with all these stressful changes and things, it's certainly a possibility that homeschooling could be beneficial, in maximizing at least their immediate happiness and self-concept and things. But a person does have to think long term, and thinking about the next 3, 7, 10, 20 years, whatever it is. What does that look like? Because oftentimes if we move from schooling to homeschooling, in order to reduce anxiety, and a lot of the times to reduce anxiety and stress, that will happen, but oftentimes we just then it can reinforce the anxiety. That's how anxiety disorders get started to begin with, is by avoidance and reinforcing kind of that avoidance, that escape. So it makes it harder in the long run. But again, I think those are excellent questions, and now is probably a perfect time to ask it. I think that's something that an evaluation could be helpful, or talk with his psychologist and talk with his medical team. Excellent question. So here's another question. 25-year-olds, and does anxiety and depression increase as the disease progresses? So just in general, yeah, I mean, we think that, but these boys are highly resilient. And when you look at their overall quality of life, and you look at their overall kind of rates of anxiety and depression, it really does not deviate that much from the other boys that don't have Duchenne's, but they have other conditions that are limiting, as far as muscle weakness or other orthopedic conditions, things of that nature. I think there seems to be a risk period in that transition between childhood to adolescence, around the age of 10 or 12, that we really see that increase, that we're starting to become more dependent on others or more wheelchair bound. I think we really see that major increase there. But again, the risk does increase over time, but there's, again, a lot of individual factors. I'll just, again, really highlight the fact that over time, these boys are really resilient. Yeah, so this is a question about math. So math can be a struggle. So why are they so good in the computer world? Well, again, I would say that we're probably dealing with, first, at the brain-based level, there are different brain systems that would be utilized there. Number two, we're probably dealing a lot with motivation and reward system of the brain, that as soon as we're on the computer, as soon as we're using technology, we see a lot of, and not just Duchenne's, but a lot of boys, a lot of young adolescent boys, young boys, just really gravitate towards technology, gravitate towards screens. And once you have that attention optimized, it's unbelievable that kind of where you can see them go from there. And that's where we really encourage as much as possible for these boys to get as much hands-on technological kinds of strategies utilized at school is really helpful. It's really helpful for their initial kind of engagement, their willingness to try different things. All of a sudden you get them interested, they can pay attention longer, they can focus longer, etc. But it really, and just as far as the math goes, again, it really does come down to what specific aspects of math are more challenging. Again, some visual aspects can be a little bit better, but at the end of the day, and if it requires working memory or more of those short-term kind of verbal skills, we do see, again, a lot more challenges. And here's another question. I can't speak too much to this. I'm not a psychiatrist. I'm a neuropsychologist, so medications aren't something that we describe as a certain as an area of expertise, if you will. But the question is about there's a swab test to see which medications would work best for our sons. Those do exist. So uh, there are techniques to see kind of how our body metabolizes different neurotransmitters, for instance. And in theory, I think the research is still in its infancy, but there is research out there to say, okay, if that test says X, then Y or Z medications are going to be the best in order to address those sorts of issues. Certainly something that you could consider. I don't know specifically, again, I know that research has been coming online, and it's actually a push here at our institution that they are trying to roll that out and trying to get a ton of people on board to start that research. I don't know if there's specific, research out there looking at that kind of test, predictive effectiveness of medications in Duchenne's. I do not know that. Yeah, so this is another question, excellent question. So IEPs oftentimes seem to be all over the place, state to state, school district by school district, even school to school. I know that. Any suggestions to streamline this process? There absolutely is not. Unfortunately, it's a very complicated process, and I think schools can be frustrating. Some schools, they do everything possible, and I'm just like blown away. In other schools, it looks like, they're, I don't know if they just don't know, it's lack of awareness. I think sometimes it is in underserved communities or out maybe more rural places or what have you. I think sometimes, but other times too, I think that the school knows, but it's funding issues and they can't provide X, Y, and Z. So then they try to tiptoe around it or not look at certain things or not recommend to put certain things in place because of funding or something that they can't put in place. But the fact of the matter is, these boys and anyone that qualifies for an IEP or 504 plan they're protected by federal law. So it's important to read up, do your own kinds of reading, investigation into what they're legally obligated to do, getting a good evaluation done with good recommendations, speaking to these are the things that are required in order to optimize and really meet that basic level of education, that free and appropriate level of education that everyone's entitled to. And that's the first step. And if that's not helpful, number two, oftentimes there are educational advocates, different people that can consult or write a letter. Sometimes the schools just need an extra budge. But again, unfortunately, I know that schools are quite variable, right, in their willingness to do certain things, different resources available. And again, I think it's just the knowledge that they have a lot of the time. Here's another question, good question, about any suggestions about taking a foreign language. That is something that is very much going to be individually tailored to the child. If it is someone who is pretty typical or just has a mild kind of language issue, but is relatively of, normal intellect, that person can probably do okay acquiring a second language. Is it something that they would want to do? I don't know. They probably wouldn't gravitate towards it. Might not be something they're seeking out. Um, Anyone who's again average or above, that it might be something they seek out, and there's absolutely no issue with that whatsoever. But what I would say is that the research in general, when we're talking about kids who have a language disorder or a significant developmental delay, whether they're just their parents want them to speak a second language or whether they're from a bilingual household, um, it's challenging. It is very challenging for them to acquire both languages. It's not uncommon for them to have a little bit further exacerbation of some language um, development, or for them to really only be able to acquire one language, even in kind of the bilingual household, if you will. So that again would have to be individualized to the child, the developmental period where they're at. Language skills develop a lot easier before the age of 3 if they're getting full exposure to bilingual, 2 different languages versus after that stage. All those things do play out, but that's an excellent question. Again, in the context of these kids, a lot of the times have language issues. So, yeah, another good question, and this is about one kind of child being more isolated now. I assume because of making an assumption because of COVID, but um, also has sensory processing issues. So, not being around people, not maybe having as much structure, and we're seeing an uptick in sensory issues. Um, it is not uncommon for any change of our environment to cause an increase of these symptoms that maybe only happen transiently, especially under well-controlled conditions where we know what's expected and what's coming next. A lot of these boys with Duchenne's, whether or not, again, some of them meet criteria for autism, some of them don't, but in periods of time where it's unexpected, there's an unexpected change, or there is a deviation from things that they're used to, or different environmental stimuli, different noises, uh, sounds, smells, whatever it is, then you can see again an increase of those rigid type behaviors. Those rigid type behaviors, whether it's true obsessive compulsive disorder or it's just that difficulty doing the next thing, digging in, saying no, um, shifting, getting overwhelmed, having tantrums due to a small change in schedule. It's not unusual for that to increase. And again, anxiety built in and inextricably tied to these things. In that particular case, there is a question also about medications. Again, if it's driven by, if that uptick has been driven by anxiety, now I would say, again, it's likely that that's at least a feature, a partial component. Then potentially medications could be helpful with that, right? But if it's more directly tied to sensory processing issues or different things going on in the environment, and that's the main change, and it's not necessarily increased anxiety, then medications, there's not probably a specific medication that could be helpful with that. So that's an excellent question, which again, it's something that pretty common, especially if it's a young boy around the age of 6 or so. That certainly could be, again, common. You should almost expect that. I wouldn't say that immediate kind of jumping to use of medications is necessary unless it's absolutely compromising, again, his their quality of life or presenting safety issues. But increasing your own structure at home, using good use of, maintaining good expectations, setting a schedule for the day, and maintaining those things, across environments, across caregivers is all helpful. Increasing that productivity and predictability and consistency across caregivers and households and schedules is all helpful. So how do you address focus, mood issue or mood challenges when neuropsych testing is normal? I want to read the rest of this question. Yeah. So how do you address, again, the focus or mood issues when neuropsych testing is normal, or we're seeing normal things, or they're seeing different things at home versus school or in testing conditions? And um, you know I think that speaks to a couple things. So clearly, there are different environmental things going on that different behaviors come out in different settings. And with anybody doing evaluation knows that. And I think that most people also know that. Lucky for you guys as parents, right, that your child loves you and they're willing to show you all of their emotions and all of their behaviors, right? Despite how challenging they might be to work with. Um, a lot of kids, a lot of individuals, they can hold it together at school for whatever reason. Maybe they want to, they're just comfortable there, or they know what the expectation is, and they're able to hold it together for 6 hours, 8 hours, whatever it is. But then they're exhausted by the end of the day, so they let that hang out once they get home. Sometimes, again, maybe it is just pure fatigue that they're doing fine. They're just really tired at the end of the day, and they're more prone to having those emotional outbursts, etc. at home. So I would guess that anybody doing the evaluation, that they trust the reports and they know that that's accurate. They might not see the direct behavior, but I think the recommendations can be just as useful. And when we're talking about those types of behavioral differences, again, really what the recommendation generally is, really, if you're having challenges with that, to work with a behavioral clinician, psychologist, um, um, a social worker, to do kind of more parent management type strategies. Okay, like the child's able to hold it together in these different situations. How can we mimic those situations here? Or what else is going on? And then we can tweak our environment or tweak what we're doing as parents just a little bit, right? And sometimes it might be some of those other things that we know that it's not the environment necessarily, but it's more the situation. They're tired. They're beat down from school from the day, whatever it is. So then, making sure that we're building in breaks once they get home, or they're. I try to avoid naps, right? But if needed, like that sort of thing needs to be built in as well. Just because it's not uncommon again for our test findings or different behaviors to be shown to us than what the parents are seeing all day, every day. But I assure you, it's not that we don't believe you or that we don't think they're existing, because they are, but really it's the same kinds of you know recommendations that we would make regardless. Now it is true, again, if you're looking for a diagnosis and they don't see it, some diagnoses are harder to make when we don't see that. But the fact of the matter is, if a lot of the times in order to make certain diagnoses, that behavior does have to occur at least across multiple settings, if not all of them. So then it would probably not be indicated. But that's an excellent question. I think a general kind of theme that you're probably hearing here is that it's really hard to make a single kind of blanket statement, right? There are kind of decision trees I think I can walk through, but it really comes down to who your individual child is, right? Your child is not Duchenne's. Your child is not ADHD. Your child is not anxiety. He's not a behavior problem, right? Your child is whatever his name is, and he is unique and different and complex, and that's who we're working with, right? And the only people that can truly, again, really get into who he is and really bring those things home to optimize his life, your guys' life, is, everyone who's working with him. And that starts with you guys as parents, starts with his clinicians and his multidisciplinary, neuromuscular team that are doing everything they can, again, to optimize their treatment and things. I'm going to click through another one. So I think there's either another question or a second component to that, with asking about corticosteroids. So that can be hard to tell whether it's due to corticosteroids, other than if you don't know, then it probably isn't a big deal. The issue really comes with, okay, we were doing fine, and then we started corticosteroids, and then we saw this, and then we took it away, and then it was fine again. And then we tried it again, or we, tried a different dose, or we increased the dose, and the same thing happened. Then I would say it's pretty clear. That's more, I think, looking at when it was given, if it was an increase in dose, etc., and if that kind of immediately was followed by those changes in behaviors and emotions. And it's really helpful too if, you guys are seeing it, but then also his teachers or grandma and grandpa or whomever else is seeing him too. Again, it really helps to validate that. Now, there isn't too much you can do about it. A lot of parents, unfortunately, do choose to not continue the medication. Some kids it's hard for them to tolerate, and it's really challenging to work with their behaviors at home because of it. And you do have to make a choice. And again, it's our job to help you guys enhance quality of life, and no one knows what that quality of life is better than you, better than your son, right? So we need to meet you where you're at, but at the same time, we need to work to continue to encourage best practices and things that we feel like the research supports long term from a healthcare perspective. Lastly, it is a realistic request to keep the school aid from middle to high school to keep consistency and trust. Great question. Absolutely. It obviously depends on, and this goes back to the other great question about, the frustration between different schools, different school districts, or different states. So what that implementation looks like. I can just say, even here in Arkansas, this type of thing, and it, individualized to the child, but that's a recommendation I've made, and it's gone no problem. Very helpful school, loving, caring, aid, perfect fit with the child, life is good, quality of life is optimized, right? But then there's these other situations too where it's like, okay, either we need a change of aid or they're absolutely in love with their aid, they don't know what they would do without it. We're going to have issues if they take away their aid next year. Not only will they not have an aid anymore, but they're refusing to provide one in high school. And then again, we're left with what do we do? And that's where all we can do is, get professionals to make that recommendation if it's warranted based on what your child's kind of abilities are and what the needs are. Get that in writing to advocate for that on the IEP or special education program and see where that goes. And the next step, then the last step, is that if we do have a lot of challenges, there are people that sometimes they either do it pro bono or there are different people that you can just consult with that their job is to help at least advocate for the schools follow certain recommendations and or federal law essentially if that's something that's being deviated from. But keeping aid from middle to high school as needed is absolutely great. Absolutely. Those are the main questions I see here. I don't know. I hope I didn't miss too many. A lot of really great questions. But anything else? I don't know if you're still rolling in or.
Thank you so much, Seth, for answering all those. Those were fantastic questions. Thanks everyone for submitting them. I don't see us getting any other ones. So, with that being said, if anyone has any other questions, please feel free to shoot us over an email at Jet Foundation. And we're happy to share those with Seth. And this presentation will go on our website in a few days as well. So please feel free to share with others in the community. Feel free to rewatch it and share it again. Thank you all so much for joining us, and a big round of applause to Seth for coming on today. It means a lot to us in the community. So thank you, Seth.
Absolutely. Thank you very much for having me. My pleasure.
Awesome. Well, yeah, if there's nothing else, I'll shut down this webinar so everyone can get back to their daily lives and stay safe. And thanks again for joining.
Great. Thank you.